Can I say thank you very much for inviting me? I'm not really talking and have any knowledge about tourism. I'm here as a medic to try and highlight to you guys what we do know, what we don't know, and what we're trying to do about our lack of knowledge. Very quickly, we've known about carbon monoxide and certainly coal fumes for 2,000 plus years. And if you look from the point of view of medical research, most of what we know and use as medics now, we knew about the early part of the 20th century. Since then, it's been a bit of a desert in clinical research. There's been bits and bobs in terms of some treatments and other things, but on the whole, nothing much has happened. Professor Wesley, there's his group at Cranfield. The boffins, as we call them in medics, the scientists, are doing a lot of work, but we are missing things. We're missing a trick in medicine. What do we know? Well, we know carbon monoxide is bad for you. We probably miss quite a bit. It is probably one of the leading causes of death by poisoning, certainly in the UK. And it probably causes a lot of harm. But probably is the big word that I've repeated there. We don't know. We have a measure for it, but it's got significant limitations and people don't know how to interpret it. So what are we doing? Now I'm going to talk about the research that I've done, and I'm aware that Cranfield are doing a lot of work. Merseyside Fire and Rescue have done a huge amount of very good work on raising awareness, but the guys who do the treatment, we are missing patients, I am sure. We undertook a prevalence study, finished in 2012, looking at patients who come to the emergency department with symptoms that could be related to carbon monoxide. We measured the carbon monoxide using this machine, but also doing blood tests. VBG stands for venous blood gas. Pretty much every emergency department has a venous blood gas machine, and it should run carbon monoxide levels. We recruited 1,777 patients, and we found that there was quite a high number of patients who had higher than expected carbon monoxide levels. However, smoking was a difficult thing. We found a number of patients who smoked who didn't tell us about it subsequently. So whether we cannot say that this is due to carbon monoxide exposure, but it was higher than we thought it would be. And in some cases we did find sources of carbon monoxide exposure. So we know for a proportion of those patients they were being poisoned. And I suspect a proportion of those patients, quite a large proportion, unless we were running the study, we wouldn't have realised it. We had a few problems. Smoking is a huge problem. It puts your carbon monoxide levels up, and people don't always tell us. People like to tell doctors what they think the doctor wants to hear. The monitors, this is a big point. The non-invasive monitors, this is the data we got where we compared the monitor with blood gas levels. And it should be a nice straight line. As you can see, it looks like the statistician has sneezed on the page, and therefore we can actually say, I don't think these monitors are very good. And they're certainly not reliable enough in a clinical setting. I came into a lot of problems with the company that makes them, getting phone calls in the middle of the night, but I can't deny the data that I think the Masimo monitors are not up to scratch at the moment. What are we going to do about it? Well, we're actually going to redo a project again, and it's one of the nice things about these meetings and the all-party group is getting people from other groups together to get their expertise on board. And this project, we are going to use some of that expertise from this group of people, and hopefully, we're in the planning stage, we are going to actually look at the evidence base for what is a positive carbon monoxide level. So myself, two of my registrars and the Professor of Epidemiology and Statistics at Surrey University are currently undertaking a meta-analysis of the papers, and there's quite a few, 160 to be precise, looking at smoking and carbon monoxide. So therefore we will get a proper idea, hopefully, of what we use as a cut-off. We're going to get gas engineers, hopefully, if we can get the money for it, to go out and actually assess the scene. Let's find out what the carbon monoxide levels are at the scene. Let's see what appliances are faulty. So we can then say, we can actually go from the scene to health, actually get that connection between whether people are being poisoned or not. There are various other things, other biomarkers that we are being tested at the moment, and there's quite a few being tested. Our group are testing some new ones. In the last year, I've reviewed 3 papers for different journals looking at different markers. The problem with carbon monoxide levels is you start to breathe them out, and if there's a delay, and of course every emergency department you get seen straight away, and there's nothing like a 2-3 hour wait to be seen, the levels may have gone down and we have missed the boat. So is there any other biomarker that we can use, any other protein or anything else that changes with carbon monoxide?